if I could only tell the listeners or women one thing about perimenopause, it would be that, yes, it is a normal part of life, but you don't have to suffer through it. And there's many evidence-based treatments that can improve your quality of life and help you feel and function your best. Because like I always say, normal isn't always optimal.
Welcome to This is Perimenopause, the podcast where we delve into the transformative journey of perimenopause and beyond. I'm one of your hosts, Mikkel.
And I'm your other host, Michelle. And together, along with about 1 billion other people on this planet, we're embarking on this milestone of life. We personally struggled for years with perimenopause symptoms, and it took us a while to figure out what was happening. Even now, there are some days that are still a struggle. We know firsthand how confusing, overwhelming, and downright scary this phase of life can be.
So we're on a mission to help others be better informed than we were when we started our journeys. Our podcast is a blend of health, education, mindset, and personal growth. We're sharing real-life stories and expert advice to help you navigate this journey and advocate for your best health.
Because this stage in our life is an incredible opportunity. We used to think menopause signaled an end, but really, it's just the beginning.
This podcast is for general information only. It's designed to educate, inspire, and support you on your personal journey through perimenopause. The information and opinions on this podcast are not intended to be a substitution for primary care, diagnosis, or treatment. The information on this podcast does not replace professional healthcare advice. The use of the information discussed is at the sole discretion of the listener. If you are suffering from symptoms or have questions, please consult a qualified healthcare practitioner. Hi, Michelle.
Hey, Mick. How you doing?
Good. I realize this probably isn't the best top to be wearing on this. Does it read backwards for you?
Well, it's better than mine. I'm looking naked still, I think. But it gives us a little
spicy,
something racy,
spice things up
to talk about. Spicy. We're spicy like that. Yeah, I'm super excited today. I've not met Shelby. Just a few minutes ago in the green room, pre-production talk. But Mikkel, you've told me so many amazing things and about the program and about what she's doing. And I'm super excited to meet her.
Yeah, exactly. Why don't I give you her bio? It's very impressive. And then we'll dive in.
Sounds great.
So Shelby graduated with a Bachelor of Nursing from Memorial University in 2015. She started her career in labor and delivery at the Health Sciences Center in St. John's and later moved to Rocky View General Hospital in Calgary, where both my babies were born, just FYI. Shelby's passion for women's health and preventative health care led her to pursue a Master of Nursing Primary Care Nurse Practitioner degree from the University of Saskatchewan, graduating in 2021. Recognizing the gaps in hormone health for both men and women, she actively sought further education, including attending the Academy of Preventative and Innovative Medicine Bioidentical Hormone Optimization series. Shelby embraces an evidence-based and holistic approach to hormone health, integrating wellness pillars such as movement, sleep, nutrition, and mental wellness, along with individualized supplementation to achieve optimal hormone balance. As I said, quite the bio. Welcome, Shelby. We're so delighted to have you with us today.
Yeah, thanks for having me.
Great. Maybe we'll just get you to elaborate a little bit on your background and how you became interested in hormone optimization.
Yeah, so great question. I think, honestly, it started with my women's health background. So as you had mentioned, I worked actually in labor and delivery as a nurse when I had started my nursing career. And then I came to Calgary and again worked in labor and delivery. But I knew I kind of wanted to do more education. And that's kind of what led me to pursue my master's of nursing and become a nurse practitioner. And when I was doing my nurse practitioner training, one of my clinical experiences, I actually had a lot of experience with women in this perimenopausal or menopausal transition of their life. And I kept hearing them say things like, I've been to so many people and everyone just keeps telling me it's normal. It's an expected part of life. And the frustration with being unable to find support to discuss what they could do about those symptoms and improve their quality of life. And that's kind of what got me thinking, well, there definitely has to be a better way than just kind of telling women, this is just how it is. And that's ultimately what sort of led me on this whole journey of connecting with Preventous. And as a result, I pursued further education in terms of hormone health and hormone optimization. And as you had mentioned, I did complete some training under one of the world-renowned hormone experts, Dr. Neil Rouzier, who his program spoke to me because it's very evidence-based. Everything he lectures is off of studies and evidence. So it really provided me with a knowledge base and foundation to start the program, Hormone Optimization by Preventous.
And just so our listeners,
for clarity,
sorry, go ahead.
Go ahead, Michelle.
I was just going to say, I'm not in Calgary. I do know a little bit about Preventous because of Mikkel, but as I understand, is it a private clinic?
So if listeners who are not familiar with Preventous, who don't actually live in Calgary, Preventous is a medical clinic in Calgary that is a private clinic. It focuses on comprehensive and proactive approaches to healthcare. And it's really more of a team-based approach. We have many different practitioners such as dietitians, kinesiology, athletic therapy, as well as nurse practitioners and physicians that all kind of work collaboratively to address health issues from more of that pillar of wellness approach, and not kind of looking at disease and more looking at how do we improve health span. So that is kind of one of the reasons I connected with Preventous in the first place. Was the medical director, Dr. Rohan Basundas, and I sort of connected on that individual and preventative medical model, and shifting that idea of medicine traditionally is focused on treating illness. And I wanted to have an approach that was more preventative and focused on optimizing pillars of wellness. So that's a little bit about Preventous.
Sounds like an amazing clinic.
Yeah, it is. It is quite the special space. It is for sure. What about, so this hormone optimization program is new. Maybe you can dig into that a little bit more for us?
Yeah, absolutely. So with the hormone optimization by Preventous, this was kind of an idea that started from my first interactions with Dr. Basundas. I had expressed an interest in hormone optimization, and this is something that he didn't really know a lot about, but he is very much a champion and proponent of optimizing your health and your wellness. And hormones is a whole other entity. And so through his support, I got into more training and more education in that realm. And then also from just hearing from patients of they were struggling to find that support in our traditional medical system. And so I wanted to create a program that sort of challenged that idea that what is normal, and normal isn't optimal. And truly, what is normal? I think that generally speaking, our medical model focuses really on that quality of life piece or quantity of life, when we should really be focusing more on quality of life. We've done a really great job at extending our lifespan through all the medical advances, but what we are missing is really maintaining that quality of life as we age. So that's kind of what started this grassroots idea of this program. But my program specifically is an annual subscription-based program. It's very individualized. It's a comprehensive approach to hormone concerns. And during that first appointment is really when I dive into understanding your health history, really getting a sense of what your hormone health concerns are, your past medical history, and really kind of working with you to find a strategy that we can work together and address those concerns. And ultimately, my biggest goal is helping people feel and function their best.
Yeah, I think that's really important, is that what's considered normal often doesn't mean you're going to feel like your best self, and that those ranges can be fairly significant and really don't address the fact that we're all very unique, right? And present very differently. There is, maybe we can just touch on this. There are medical practitioners, more traditional physicians who talk about, hormone balance isn't a thing, but that's not really what you're talking about. You're not really talking about balancing hormones. You're talking about getting people to a place where they feel their best. Is that, am I getting the right take on that? Or can you talk about that a little bit?
Yeah. So you're right. It's not about it's not, when I look at blood work, for example, on a patient, I'm taking that in the context of who they are and what their story is. So I always tell people your story is the biggest part of the picture and your lab work is just kind of additional. I use lab work more as like a way of ruling out anything big or bad that we should be focused on, like a thyroid dysfunction or iron deficiency. But in terms of hormones and hormone balance, especially in women, we know blood work isn't super reliable because women cycle, and in perimenopause, you're still cycling. It's just not as smooth as someone who's in their reproductive years. So looking at that hormone balance piece is not really helpful. What I'm trying to do is that women are presenting with certain symptoms related to these hormonal fluctuations that happen in perimenopause. And I want to try to address those symptoms and make you feel and function better. So not so much relying on numbers and lab work as a guide, but more using it to help make sure other aspects of your life are aligned, but not as the guide, because you're right. There is no true balance per se, especially in women's health, but they can definitely help guide treatment.
Right. Guide treatment. And as you say, rule out things that could be problematic or that need to be addressed, like a thyroid challenge or low iron, which is really important. And I guess very common in perimenopausal women as well, as what I understand. What would you say, is there a common thing you're seeing in women who are, of that age, perimenopausal age, which is, kind of 35 plus to 52, I think, we're creeping up on that average age of menopause at 52 in Canada. Are there common things that you're seeing in those patients?
Yeah, I would say the most common thing I'm seeing, if there's a common theme that's presenting with the patients that I'm treating in this age group, it's really that sense of frustration regarding, experiencing symptoms of perimenopause or menopause that's affecting their quality of life, but feeling like they're a bit alone in that journey. And for some women, so symptoms of perimenopause, just for anyone who might be wondering if what they're experiencing might be a symptom, changes in your periods. So for women, often either more regular periods, heavier periods, like soaking through, a pad or a tampon within an hour, waking up in the night to change your tampon or pad, hot flashes, night sweats, sleep changes, weight gain is a big one, or difficulty losing weight. And for a lot of women who are used to being like super active and have always been that same weight their whole life, what I'm noticing is women who have this, routine or regimen that they do for healthy eating and exercise, and they've been the same weight their whole life, and they're coming in, they're saying, I have gained 5-10 pounds and I just can't get it off. And I haven't changed anything else, but here I am and I don't feel like my best self. And so that's another big one that's part of that menopausal transition. And then of course, things like mood changes, brain fog, anxiety is a big one that people don't often attribute. And often when you go into your family practitioner, whether it's a physician or a nurse practitioner, they might kind of shrug that off as, anxiety that's not or hormonally related, and then treat it differently, when maybe in fact it's a hormonal imbalance that's actually impacting that anxiety. And then finally, things like libido changes, so changes in your sex drive, which can obviously is multifactorial, but can obviously impact relationships significantly.
Yeah, not to mention vaginal dryness, vulvar issues that also, right, can be, it's just, the list never ends.
Absolutely.
Does it? It never ends.
No, absolutely. It's funny you say that. I was listening to a podcast the other day, and one thing they said was that everything dries up. Any bit of moisture in your body leaves. And I was like, that's so well said.
I just listened to that this morning.
I was like, that's so true. So
it's like from my eyeballs down to everything was just gone.
Yeah. So that, and then that also affects things like, you're saying about vaginal dryness. I mean, that has a significant impact then on your sexual health as well, because obviously sex tends to become a bit more painful when there's less lubrication. And so it can also impact things like having more urinary tract infections, because when there's more dryness there, we're more prone to that. So there's a lot of different health implications that we don't maybe think of right away as attributed to perimenopause.
Well, and on that, along those lines, one of the ones that's bugging me right now is urinary incontinence. Like I'm like, can't get to the toilet fast enough. I pee like all the time. It's frustrating and uncomfortable, and I don't know what the answer is, but we'll see.
Yeah, I'm sorry to hear that, but that's another common one that I hear in my clinic is in relation to that. And there are definitely lots of therapies that can help. Multidisciplinary approach is always obviously best, but it is a common symptom of perimenopause that, again, women, even with incontinence, are often just told that's how it is, especially if you've had kids. If you've had kids, it's always one of my biggest pet peeves is we always used to say, oh, well, you've had kids, it's normal to just leak when you cough or, laugh or whatever. But yeah, okay, it's maybe typical, like we can expect that, right? But should we accept it as normal? I don't think so.
I agree.
I used to follow a hormone specialist, or a woman that did a lot of hormone things, and she would often say, it may be common, but it's not normal. And I feel like that's very true of so many of our symptoms. And we've just been told, well, that's normal and suck it up. So it's great that we're changing that narrative.
Yes, which I love,
absolutely.
because I love that you guys have created this platform to create more awareness around perimenopause, because I do think a lot of what's going on right now in women's health and healthcare is that knowledge gap. I hear a lot of women say that they thought this only happened in menopause. So while they're still having periods and then they get these symptoms, they're like, why is this happening to me? It's only supposed to happen in menopause, because they have no idea and no one talks about it. So I really love that you guys have kind of started this platform to educate more on that perimenopausal aspect of women's health.
Thank you.
Yeah, we've also found, we've read about this, we've also found personally and through a lot of our followers that most medical providers don't really know much about it. I can remember on 2 occasions being dismissed with symptoms that I was finally pretty sure after a lot of my own research were perimenopausal. And both of the doctors in this instance saying, well, do you have irregular periods? Which I didn't. And they said, are you experiencing hot flashes or night sweats? Which I wasn't. And they said, well, then you're not in perimenopause, which is also hugely frustrating, because I think there's also this notion, even in the medical community, that, unless you've achieved those, or unless those 2 things have happened prior to achieving menopause, then you're not in perimenopause, which I think is, based on my own experience, is incorrect. I don't know if you have any comments on that.
Yeah, that is the most common thing I'm hearing from my patients who are seeking out this additional service that we offer here at Preventous, is that they have just felt unheard and not validated in whatever healthcare model that they're currently accessing. And I would love to say that, every practitioner who's out there truly gets it and understands. But I think that, number one, we as medical providers don't learn a lot about this in our healthcare programs. And so I think that's one aspect that's kind of missing. The other is that primary care is so vast right now, and not to make any excuses about the fact that there's time constraints and there's other issues with our current medical system in terms of access and getting that quality time with a provider. But I think that does contribute in some sense, because practitioners just don't have the time to keep up on the latest research about everything they're seeing in primary care. So if you don't really devote a lot of time to understanding it, I think you would have a really hard time navigating it and treating these kind of conditions. And unfortunately, as we know, women's health kind of goes on the back burner. These are all quality of life issues, meaning they're not going to kill us. To be blunt, we're not going to die from the symptoms of perimenopause or menopause, but that doesn't make them any less important or any less valid. And I think that's the part in healthcare that kind of gets dismissed, because we end up, because of the time restrictions we do have and the capacity restrictions that most practitioners have, dealing with the most severe symptoms first is kind of where we go with things. So it's almost like the life over limb emerge model that's kind of migrated into primary care because we have such a shortage of providers.
Taking the shortage out and their capacity, have you noticed any changes happening within the education system? Like is women's health becoming more prominent, or are we just, I'm hearing that it is, but I'm just wondering if that's actually true, or if I'm just choosing to believe that there's a light at the end of this tunnel.
I think that's a great question. I like to think that things are getting better than they were, but I don't think that they're any bit near where they need to be in terms of us truly understanding women's health and hormonal health. I think there is very little taught about, for example, even just birth controls. There's very little taught about the differences of the different types of hormones that are in birth control pills, IUD, Nexplanon. They all have different types of hormones, synthetic estrogens and progestogens in them. But we don't, as providers, learn why we would want to prescribe that one versus another synthetic. And I think a lot of that comes down to, again, generalizing a bit more with women's health. And so the same thing goes into perimenopause and menopause. When we get into treatments like hormone replacement therapy, there still isn't much in terms of distinction in regards to synthetic and bioidentical hormones, or even just the birth controls as a result, like, IUDs versus oral contraceptive pills, why one person would choose one over the other versus using bioidentical hormones versus just synthetic estrogens or progestogens. We don't distinguish that in our education system. And I think that that's one piece I would love to see expand. But I do think things are better than they were.
That's reassuring. That's reassuring for sure.
Yeah.
Maybe just, you've touched on bioidentical versus synthetic, or I guess bioidentical versus synthetic, and then there's also compounded versus pharmaceutical. I'm wondering if we could just touch a little bit. I think, from my understanding, is your program focuses on bioidentical hormones. Is that correct?
Yes, you are correct.
Yeah, and so maybe you could just talk to us a little bit about those differences.
Yeah, for sure. So bioidentical, I think, gets a somewhat of a bad rep in some of the controversy because people put compounds and bioidenticals together and think they're the same thing when they're not. Because there are like Health Canada approved bioidenticals like estrase, for example, which is estradiol, or prometrium, which is micronized progesterone. And those are approved by Health Canada. Compounding is a whole separate entity, which I can mention in a second, but synthetics are things like, people might be familiar with the terms Premarin or Provera, Premarin being synthetic estrogen, which is conjugated equine estrogen, and Provera being a synthetic progestin. And they were the most commonly prescribed medications for a long time. And still today, there's a lot of practitioners in Canada and the US that are using these formulations. The challenge is that the bioidenticals have a better safety profile. The data we have on them is better in terms of outcomes and mitigating some of the risk factors that we see with traditionally the synthetic hormones. The bioidenticals tend to be better absorbed because they're essentially chemically similar to what your body was already producing. So first of all, bioidentical estrogen is actually estradiol. And estradiol is the most common estrogen that we have during our reproductive years. Whereas in comparison, something like Premarin or conjugated equine estrogen contains multiple estrogens that are not even found in the human body. So as a result, you can kind of see how your body might metabolize those two medications very differently. And the same thing with progesterone. Micronized progesterone is simply that. It's micronized progesterone. So it's exactly what your body produces. Now, on the other hand, things like Provera, which is a synthetic progestin, it is molecularly different and has actually been the one that's shown probably more of the harm in all of those studies that we know about. than the estrogen itself.
Right. And the big study would be the Women's Health Initiative, right?
Exactly.
That I think was abruptly ended in 2002, right?
Yeah.
And what can you talk to us a little bit about that and just the impact that that's had on women's health, midlife health, I guess?
Yeah, absolutely. I like to think about that as the basically demise of hormone replacement therapy for women. And it is quite unfortunate that we have based so much of our care off of this one study that was significantly flawed. The study was the largest study to date in terms of this topic of hormone replacement therapy in women. And as I mentioned before, it studied the two synthetic hormones. So conjugated equine estrogen, or Premarin, and Provera, so the progestin. The challenge with the study is it was significantly flawed. So first and foremost, done on the wrong people. So people who were more than 10 years post-menopause. Average age of the study was, kind of in that older age group in their 60s, 70s, when we know the average age of menopause is 51. So not really representative of women in that perimenopause, menopausal transition. They also didn't really screen. They said everyone was healthy, but there was high rates of diabetes, obesity, hypertension, and different comorbidities that might have put them at an increased risk for all of these disease processes. And then finally, the fact that no one in the study had symptoms, because if you had symptoms, you would know whether you were getting the treatment or placebo. So it would have skewed their blind study.
Oh, interesting.
Yeah. So from that, we generalized information to all women and all postmenopausal or perimenopausal women. The challenge is if you actually peel back the layers of the data, first to explain, there was two arms of the trial. So there was an estrogen only arm. That was women who had a hysterectomy. And the reason being is because if you still have your uterus, you need to have some sort of progestogen, whether it's progesterone or progestin, to oppose estrogen, because to reduce your risk for endometrial cancer, which is when the cells of the endometrial layer of the uterus they kind of grow out of control. So the way I tell people is like estrogen is like a lawn fertilizer, and progestins are a lawn mower. And you need your lawn mower, otherwise you're going to grow a really rich set of grass. And unfortunately for women, when things grow wild out of control in the body, that's when we get precancerous and cancerous cells. So that's why one group had only estrogen and the other group had both. Now, when we look at the two arms of the study, we see that women in the estrogen only group actually had a decreased risk for breast cancer. Now, again, not statistically significant, but a decreased risk, as opposed to the other arm of the trial where that was part of the reason it was stopped, is because of the increase in breast cancer cases. However, when you actually analyze the data, it was actually only one case extra from 4 to 5 cases from control to placebo, or the control to the experimental group. And they reported that as a 26% increased risk of breast cancer if you took the hormones. What they failed to mention that this was a relative risk increase. So it seemed more fantastical than it was. And then they didn't show that in the estrogen group, there was actually a decrease. Now, both of these findings were not statistically significant, so they never should have been reported. But that was one big implication. And the second was the increased risk of blood clots that was found in the estrogen only group. And that's what stopped that arm of the study. So younger women, so your average age of menopause, who started even Premarin, had no increased risk of blood clot. So if we actually look at that data and peel it back, we should be able to say that hormone replacement therapy with estrogen in women who are within that 10-year window of menopause is safe. You have no increased risk of clot. It's that greater than 63 that we see that risk of clot. So that's kind of the nuances there in the study. But unfortunately, they took two headlines and ran with it. Hormones cause breast cancer and hormones cause blood clots. And particularly when we talk to women, what's the number one fear that they have? Breast cancer. And as a result, that scared a lot of women away because breast cancer, we know from studies, is the number one fear for women.
I think, too, you point out something really important. We've really lost over 20 years now of work and research and education in the context of hormone therapy, right? Because it really did scare off everyone, not just patients, but practitioners, but also the doctors, is
Yes.
my understanding. And I think what's really unfortunate is that loss, but also the loss of information for patients in general to understand that there are actually also preventative benefits other than symptom relief that can come with some of these medications, right? And again, everybody's unique and there are risks and you need to understand those, but it's really important, I think, for everybody to understand the potential benefits. And that, I think, something that's also been lost in all of this.
Yeah, it's interesting you say that because part of what got lost in that terrible study was things like the reduction in colon cancer that we saw. So for individuals that may have an increased familial risk or genetic risk for colon cancer, that could be huge. We know there's tons and tons and tons of data around osteoporosis and estrogen and how your risk for osteoporosis increases significantly at that menopausal transition. So osteoporosis and fractures being one of the leading causes of death worldwide. So that's a huge one. Not to mention cardiovascular disease. We know that estrogen plays a significant role in our heart health. And that's why we see women's risk of heart disease is significantly lower than men prior to menopause. And that transition towards menopause has a significant impact on our risk profile in terms of having a heart attack, stroke. And then not to mention some of the studies that are coming out now in regards to potential benefits for Alzheimer's disease prevention, which is something we don't really have a good treatment for to date. So there are definitely, like you said, it's not a one size fits all. You always are weighing that risk benefit profile kind of in anything you do with medicine, but women should also be informed of the potential health benefits that maintaining their hormone levels throughout the course of their life can potentially have for them.
What are your thoughts on smallest dose for the shortest amount of time? I believe that is changing somewhat. I wonder if you could comment on that and give us your thoughts on that.
I believe that's still the recommendation is kind of that shortest amount of time because basically hormone replacement therapy is not approved for treatment or prevention of chronic disease. Its only indication is to treat symptoms. So the whole idea is those hot flashes, the night sweats, vaginal dryness, et cetera, et cetera. But again, I think because we don't have, because a lot of our guidance is coming from the WHI still, there is no recommendation for the hormones in terms of a long-term use or preventative use. And as a result, many practitioners are still leaning towards the shortest amount of time and getting you off of them after a certain point.
Today, I just got prescribed HRT. I'm excited. I'm a little nervous, but I'm excited. But his comments were 5 years. I can be on it for 5 years and then I'm going to have to cycle myself off. So again, a lot could change between now and those 5 years, but that's his understanding right now. Or he's a bit old school, but
it's troubling for me that our current practice standard is that we would treat for a certain duration of time and then say, okay, well, you've exceeded your amount of time. You're done. You're cut off, because that doesn't make a lot of sense. And so now we're getting a lot more long-term data in terms of women using hormones for 15, 20 years and beyond that have had no adverse effects of the hormones. So I'm hoping that as the next 5 years come up for you, maybe he'll have changed his tune and maybe more data will be out there on that. But in my reading of the literature, my understanding of the literature, there are no studies to date that suggest that you need to cut off hormones at any point. I mean, I even have patients who are living well into their 80s, 90s on hormone therapy, feeling and functioning their best.
Wow.
Yeah, I'll never forget. I had this one little lady, and I thought to myself, I wonder if she's going to be able to make it down the stairs just based on her age. She sauntered on in here and was chipper, and I thought to myself, if I can only be like half that good at that age. And I think and she attests a lot of it to the hormone therapy that she is on, because it's kept her feeling and functioning her best.
You'll have to share those for us. We'll put them in the show notes, whatever her hormones are.
Shelby, this has been fantastic. Thank you so much. I'd like to keep going if you have a little bit more time. In the last 3 years, I think that menopause in general has sort of blown up on the internet, and there are a lot of people talking about it now that weren't before. And there are new programs like yours, but I feel like there's still a long way to go. What do you think needs to happen to address these challenges that persist?
Basically, if we can create platforms where we provide more awareness around the issue, I think education that empowers women to be able to advocate for themselves in our current healthcare system is extremely important. I think it's awesome. I can't speak about all providers, but I love it when my patients come in and tell me the research they've done and come in kind of with a plan that we can work on together, and I can, suggest some options. And I think that that's a great approach to medicine, is that if we can work more collaboratively as like a partnership or a team, as opposed to the provider being the gatekeeper, I think that will help address some of the issues. But I think the biggest thing to address the problem is we need to continue to educate women, educate providers, and also educate, it's not just women, educate men and our partners, because they need to understand. They need to understand what it is that you as women are dealing with in terms of that transition, and how that they can support you through that transition. The other big thing is women's health as a whole, and menopause has always been sort of like a taboo topic. And the more we talk about it, the more we make it more mainstream, the more people will feel comfortable talking about their experiences. And I think the more we talk about it, the more people will be more comfortable coming up with solutions and addressing those issues.
It's interesting something you said, Shelby, about working together as a practitioner and a patient. I overheard today, and not to say anything negative about my OBGYN, but I overheard the receptionist say, oh, well, she wants to come in. She read some books, and he chuckled and went, oh, well, I've read a few books about menopause. And I just thought, you know what? Like, no one's telling us anything. We need to find these answers ourselves. And shame on you. I was disappointed with that, but I think that's probably not so unusual, unfortunately.
No, it's not. And it makes me very sad because, first of all, we're more educated as a population. Women are definitely more educated and more in the workforce than ever before in history. And I think I always tell people, you're the expert in your own body. And who am I to tell you what you are experiencing and what you should do to fix it? And there's that kind of old adage in medicine where it says something to the effect of, if you listen to patients long enough, they will tell you what's wrong. And if you listen even longer, they'll tell you how to fix it. And that's something that I just keep going back to, because it's so true. Like if I enter the conversation with you as a patient, what my biggest concern for you might not be what your concern is. And I think finding a happy medium between those two things is super important in healthcare.
Amazing. You mentioned you love when your patients come in with a plan. I know for myself, I show up to the doctor, I forget half of my questions. I'm like, if I'm not prepared. But are there some things you could recommend that people do to prepare that are helpful for a practitioner like yourself to know when they head into their appointment with you?
Absolutely. You need to come in with a real good understanding of what it is you're trying to accomplish in that appointment. Because we talked about earlier the concept that there's time constraint. My service is a luxury in the sense that it is a private service, so that I do have the luxury of time with patients. Generally speaking, I know that's not accessible to a lot of patients, and a lot of patients either struggle to find a primary care provider at all, or when they do, they have short appointment times or long waits to their appointments. And so I think really understanding before you go into that appointment what it is that you are concerned about. So writing down those symptoms, this is what I've been experiencing and affecting my quality of life, whether it's brain fog, the anxiety, hot flashes, whatever it is, you want to just kind of jot that down and also make a note of how it's impacting your quality of life. It allows you to have more of a structured visit, and especially when you're crunched for time, if you really come in with like a focused agenda of this is what I'm trying to talk about today, it will really help. Because like you said, you get into that appointment, the doctor starts mentioning something else that maybe they had on their agenda for you, whether it's keeping up with your, screening for diabetes or your blood pressure checks or your weight or whatever it is that you guys were dealing with in the past. And then all of a sudden your time is up and what you had that agenda to address today didn't get necessarily addressed. So I think the biggest thing that a patient can do in order to advocate for themselves is to come prepared to their appointment. And also just know that it is a possibility to ask for longer appointment times. I know some clinics can facilitate, others can't, but you can always say that the reason this appointment is for a discussion around perimenopause or menopause, and therefore you would like an extended appointment time. Most clinics do facilitate longer appointment times for things like mental health. So it's really no different because it's a bit more of a complicated topic that can't be sort of resolved in 10 or 15 minutes. So.
Yeah, probably something that we need to start writing some letters to the Minister of Health or someone higher up the chain to get the codes changed for perimenopause appointments. Anyway, that's for
Absolutely.
another podcast. Are there resources that you recommend or you could recommend to people that they might want to check out before an appointment?
First of all, and I know we've talked about this before, but the book Estrogen Matters is one of my favorite books on estrogen, and it's very evidence-based. Mm-hmm. It really dives into the topic. I think that's an awesome read for any woman who's considering hormone replacement therapy. There's some good podcasts out there in terms of people like Peter Attia, Andrew Huberman. Obviously, this resource and your blog posts are amazing and phenomenal resources for perimenopause. And I know you guys have listed some resources on your website that I love in terms of educating patients. I also have my own Instagram page where I am sharing some evidence-based data and information, as well as different recommendations for podcasts and resources for women who are struggling with perimenopause or patients who are struggling really with any sort of hormonal imbalances.
Is there anything else that we've not talked about, Shelby, that you'd want to make sure our listeners know about, or have we covered off most things?
I think we've done a lot, but I would probably just end it out with saying, if I could only tell the listeners or women one thing about perimenopause, it would be that, yes, it is a normal part of life, but you don't have to suffer through it. And there's many evidence-based treatments that can improve your quality of life and help you feel and function your best. Because like I always say, normal isn't always optimal.
Amazing. I think that's a perfect spot to end it. Shelby, thank you so much.
Thank you guys.
All the best with your program. Although I hear from Georgie at your clinic that it's going gangbusters and I'm going to have a hard time finding you to be able to talk to you. Yeah. Or getting in. But that's amazing, right? That's amazing. That just speaks to the need and the fact that the work you're doing is so important. Yeah. So good for you for being a trailblazer. And thank you for all you do. Cause every person that gets helped is one more person who's thriving and not just surviving. So thank you.
Absolutely. And thank you guys for having me. And I really appreciate the work you guys are doing because like I said, if we just need more women speaking up and speaking to the topic because it is so important. And without us talking about it, we're not going to evoke any sort of change.
Thank you, Shelby.
Well, I learned a lot from Shelby this afternoon. Mikkel, is she your practitioner at the clinic?
She is a practitioner at the clinic that I belong to, and I have seen her for non-hormone related issues, but the program the Hormone Optimization program just started this July, and it's something you have to belong to. Apparently, it's really taking off. I think, again, speaking to the fact that so many people are struggling and can't find the help that they need or the support that they need.
It's such an amazing program, and there's not enough of it. I know that, MedCan has restarted something here in Ontario, and we've got the Mount Sinai Clinic, but it's still, the wait lists are impossibly long.
Not to mention all of the people who can't afford to pay for that type of care, which is a whole other probably multi-podcast discussion. But yeah, it's sad that it sort of comes to having to seek out a specialist like this in a private clinic to be able to get answers and support.
But she's got tons of answers. My God, that was really informative. That was amazing. I loved it.
Yeah, she's great.
I liked, especially when we talk about maybe not being able to go to the clinic, her advice on being prepared and then advocating for yourself and asking for more time, because it's not strictly perhaps physical, it's also physical and mental.
Yeah, exactly. And I think too, her point about reading up on different treatments and options and having your provider say, oh, no, that's not a good idea because of actually X, Y, and Z, or okay, maybe we can explore that. I mean, I think that's really what care should look like, right? I think the days of showing up to your doctor's office and them spending 10 minutes with you and saying, oh, you have this is what you're going to take, really should be over, right? It should be, here are the options and what would you like to do?
Thanks so much for listening to the show. If you like what you hear, please take a moment to rate and subscribe to our podcast. When you do this, it helps to raise our podcast profile so more women can find us and get a little better understanding of what to expect in perimenopause.
We also read all the reviews, the good, the bad, and the ugly, to help us continuously improve our show. We would love to hear from you. You can connect with us through the podcast, on social media, or through our website. Our information, as well as links and details from our conversation today, can be found in the show notes.